So I'll be brave if you're brave. I'll be brave, but only if you're brave.
Good evening, everyone. Welcome to tonight's Lung Cancer Living Room. So happy to have all of you in the room live and those of you watching virtually from your own living rooms, as well as a big welcome to those of you who will come back and watch post live. As you know, this meeting was really created with people diagnosed with lung cancer and their care partners and family members in mind, with the whole thought process of bringing to you live and in real time information about what's happening right now in this space and how it might relate to you and your care, regardless of where you are in the cancer experience. So welcome to all of you. I'm Danielle Hicks. For those of you who may not know who I am, I'm Chief Patient Officer at GoTo for Lung Cancer, which really just is a fancy way of saying that I oversee all of our patient support services, programs, and education, just like this one. For those of you in the room, I know you're old veterans to this meeting, and so you know what all those programs and services are, but if you're new and you're watching and you want to check out what other opportunities there might be for you to connect, get support, and educate yourself on lung cancer, please just reach out to us at GoTo. We're very excited tonight to have another veteran to the living room, Dr. Kyle Hogarth, who flew all the way out from University of Chicago and is on his way to Singapore.
Thailand.
I got that wrong last time.
That was close.
Thailand tomorrow. So he made
tomorrow to Thailand.
Yeah.
Tonight, actually.
So he was oh so kind as to make a pit stop here on his way out to talk to us about something that I know is near and dear to my heart. I'm going to call her a guest now because it's been so long since she's been here, but to my mom, Bonnie Adario's heart. And if cameras can pan over to her and you can just give a big wave to all those who have missed you through all of this. Big wave. Yep. To talk about pulmonology. As you know, and for those of you who have been watching this program for a long time, we bring this topic in quite often because we feel it's incredibly important to continue to remind you why it's important that you have a pulmonologist as part of your care team, again, regardless of where you are in your cancer experience. So Dr. Hogarth is professor of medicine, director of bronchoscopy and interventional pulmonology, as I said, at the University of Chicago, on his way to Thailand. And really, tonight we want to have you guys understand and have a better understanding of what a pulmonologist's role is, when and why you should have a pulmonologist as part of your care team, and really a sense of empowerment, because I know that a lot of you are either phone buddies and are part of a mentorship program with other more newly diagnosed patients, or involved in online programming or communities where patients and people diagnosed with lung cancer are talking with and giving advice to one another. So I really want everybody to feel empowered in understanding this and being able to have these conversations with other people in the community. So before we get started, I am going to ask Dr. Hogarth to tell us a little bit about himself, so that I don't have to, because reading your bio is so impersonal, right?
True.
And probably really long. So, but just tell us a little bit about yourself and why lung cancer is like an area of...
Yeah, no, absolutely. So, I'm a pulmonologist, as stated earlier, which means I view the world as lungs and then the rest of the body that keeps the lungs working. But all kidding aside, the first expression I learned well into my training was, if you can't breathe, nothing else matters. And that's what prompted me to definitively focus on being a pulmonologist. And when you're in your training and you're sort of seeing all of it in front of you, and an academic career affords you the ability to sort of subspecialize, so there's certain lung diseases I wouldn't remotely claim to be a specialist in, but others that you do. The most profound area of unmet need that was obvious right in front of me had anything to do with lung cancer, both the diagnosis and the management of the complications and everything about it. And when you looked around, you said, there's no one doing this. I mean, this is unfortunately a while ago, meaning how old I am, but it just prompted me. It bothered me, probably the same as it bothered everybody in this room. Not just the diagnosis, the fact that no one seemed to be interested or cared. and it bothered me to the core. And so that's what prompted it. And then the rest, I suppose, just grew from there. Thankfully, there's all the things that are developing in this field, treatment-wise, have been also going on in my part of the profession as well, from the diagnostics and so forth.
Yeah, and we're excited to
there
talk
it is.
about that. Yeah, we're excited to talk about that tonight, and we're so glad that you do what you do. And can you repeat that first? If you're not breathing, nothing else matters?
If you can't breathe, nothing else
Yeah,
matters.
I love that. I got a lot of giggles, and I'm probably going to steal it from you and use it at some point moving forward. So you kind of covered a little bit that historically pulmonologists were not involved in lung cancer care, sadly.
Yeah.
And that,
And part of
go
it, I
ahead.
mean, to be blunt, part of it was we probably didn't have as much to offer then as we do now. The diagnostics, there really wasn't good things from a bronchoscopy perspective. We didn't prescribe chemotherapy, we didn't do surgery, and we didn't have radiation. Like, we didn't do any of those things. So we were only marginally a part of it. We would diagnose some of the complications and kind of deal with them, but we didn't have a lot of the things we have now. So part of it's the profession's fault from pulmonary that we sort of abdicated the space to others. But it's still, it's incumbent upon us. We're lung doctors. This is a lung disease. Yes, it's a cancer, but it's a lung disease. And it doesn't matter if it's in other places, it's still a lung disease. And so it's part of what we do, and it's part of our training. So now, of course, things have changed dramatically in regards to my trainees. They learn a ton about everything related to lung cancer, obviously, no matter what their interests are, if they go become a COPD doctor or whatever. But things evolve, just like, obviously, thankfully, the entire world of lung cancer has been evolving.
Yeah. I think that's a great, before we segue into and what we're going to be talking about are the role that a pulmonologist plays diagnostically, therapeutically, and then from a management standpoint. We've heard a lot, particularly in the last few years, about a pulmonologist and then an interventional pulmonologist. Can you talk a little bit about the differences?
Yeah, sure. An interventional pulmonologist is technically a pulmonologist. We've been trained in diseases of the lung, and that's all of them, right? So ones you've heard of, asthma, COPD, cystic fibrosis, things like that. Interventional pulmonologists are people that do additional training or have additional focus and specialize on the procedural aspects of lung disease, most of which centers around cancer diagnostics, a lot that's moving, thankfully, towards cancer therapeutics, and then a lot of other things that are lumped into the palliative category, stenting an airway that's got a tumor invading it, for example. That field's continued to evolve, and now actually there's therapeutics that we do that have nothing to do with cancer, have everything to do actually for people with really bad COPD or emphysema to help them breathe better. So because it's such, it requires a unique skill set and a lot of time, it has become its own specialty. Similar to people that do cardiac catheterizations. They are a cardiologist, but they're the ones that are doing the stuff where they go in the groin and fix the vessels of the heart, but they don't do general cardiology anymore.
Okay, that makes perfect sense. And I think, so you mentioned one word, and I just want to kind of squash any concerns that there might be about palliative and remind everyone that palliative, when we're talking from a palliative perspective, we're talking about supportive care.
Yeah, very much so.
Yeah, and I think so a lot of times it gets confused with hospice care. And,
Okay.
Yeah.
Well, so sorry if I stepped on the landmine.
Yeah, no.
But so palliative care from day one should be always part of a discussion, because in what world, this is what I always tell people. Medicine, a lot of what we do is pain and suffering. If we do a surgery on you, we're cutting you. We're causing a wound. It hurts. So it better have a purpose, right? Pain and suffering for the purpose makes sense. Pain and suffering without a purpose doesn't make sense. Not if there's things that I can do to alleviate your suffering. Even if that means there's whatever I have in front of me may not allow you to live longer, but if you can live better, why am I not at least discussing that with you? And again, I think the other key thing about interventional pulmonary and pulmonary in general is it's dialogue, it's a discussion, it's letting you know the options you have on the table. You may choose not to exercise them. You may not be a perfect candidate for something you read about online, whatever. But why aren't we at least talking about it? Why am I not part of your care team that's ensuring that you're breathing well? And all the things you and I are going to talk about that go on.
Yeah. And we're going to jump into that in a second. I just want to remind everyone, because I failed to do so miserably at the beginning, that this is meant to be an open forum. So please, please, please ask questions throughout. That goes for those in the room and those online. Michelle is over here, as you guys all know, moderating the online chat. I cannot stress enough that this meeting is for you. So please ask questions as we go along. And with that, let's jump in.
Okay.
Diagnostics.
Yeah.
So we now have better diagnostic tools. We're on our third robot. We'll get into what a robot is in just a second, how they work, but let's start in the biopsy and biomarker testing place.
So actually everybody's experience and journey with lung cancer begins with an abnormal scan, typically. You might have had a symptom, you might not have had a symptom, but at some point someone imaged you and said, there's a thing. And now it raised a question, right? And I can go give you a long list of all the possibilities of what that thing in your lung might be. And it's a long list. But until we take a biopsy, we're just guessing. And all the testing might say the probability is very high, but until the sample's taken, don't know. And even historically, again, let's talk about the evolution here. Historically, when we took a biopsy, all I had to do was prove that you had lung cancer, small cell or non-small cell. That was it. It didn't matter beyond that, even though there were all these subtypes, but you treated them all the same, so nobody cared. Thank God the field has evolved dramatically. Now I definitively need to know, not just that it's lung cancer, what subtype, what's the mutational analysis, and I need at the same time, I should be able to stage you at the same time, right? Because lung cancer is one thing, but what stage am I? So when you have this abnormality, there's essentially 3 ways to perform a biopsy. I will tell you the single greatest way, since it's what I do. But all kidding aside, you obviously can have surgery. And if you are proven to be early stage, or by various testing it sure looks like you're early stage, and that the probability is high enough, it is reasonable in certain scenarios to go straight to surgery, to have it removed. It'll be both diagnosed and removed. Now, there's a lot of caveats to that one. Because, of course, there are a lot of mimickers of lung cancer. And so to have an unnecessary surgery, where you've had part of your lung cut out for no reason, though I'm glad you don't have cancer, you just had an unnecessary surgery. That's kind of ridiculous. And thankfully, the amount of that is going down dramatically across the country. More and more thoracic surgeons will not operate without either proof of malignancy or that situation where I said it's very obvious. The other way is a needle biopsy, and that's still a predominant method in this country, unfortunately. And I say unfortunately because it's fraught with complications. A very high rate of pneumothorax, popping the lung. A rate of bleeding that is small, but with no ability to control it. And it doesn't stage the patient. So if I biopsy this thing in your lung, and I proved it was the cancer we all were suspicious of, but what stage are you? I don't know. I didn't sample a single lymph node, because I can't sample a lymph node that way. So where bronchoscopy is arguably superior is that we will do both. We will go prove what that is, make sure we get enough tissue to run the molecular analysis, and then equally important, I'm going to go sample every one of your lymph nodes and prove that there's no cancer there, so that you are stage 1 or 2 or 3 or whatever, right? Someone will say, well, I had a PET scan, and the PET scan said my lymph nodes were negative, so I'm early stage. I wish that was true. Normal lymph nodes on X-ray or on CT and normal lymph nodes on PET scan still have about up to a 10% chance of having cancer. So there's a 1 in 10 chance when your doctor says, good news, you're early stage, the scan says so. 1 in 10 chance they're wrong. And historically, this approach was, they would go and remove everything, and then they'd say, you're cured. And then 6 months later, your cancer would come back. And they go, lung cancer is so aggressive. And in reality was, no, you were never stage 1. They assumed you were stage 1. And we all know the old adage about assumptions, right? You assume something, you know exactly where this goes. I want to prove what stage you are. So bronchoscopy offers both. Now, historically, though, our ability to get nodules was still limited. And that's where a lot of the advances in bronchoscopy, actually by lots of companies surrounding this building, in this part of the country, have helped innovate and grow what we can do. And you mentioned the latest robot. That's just the next iteration of us trying to accomplish our only goal, which is to always make a diagnosis, prove what's going on, and stage you. And that's, of course, what's going to lead us to someday also treating you from the inside. We're not there yet. It's all being studied, investigated, all trials, but someday.
And we're going to talk about that. And I think for those of you who remember back in the day having these types of conversations, and you might, I don't know if you know Ganesh Krishna. Yeah, so he's come in and talked about it. I actually had the honor of being, I don't know if you call it an operatory, or what do you call the room you do these?
Bronch suites
There's a
usually,
Bronch
but
suite. That is
well,
what
but
I
some
think.
people do them in the operating room. So
No,
you-
this was
you know,
Bronch suite.
yeah.
You're right. So with patient consent for me to be able to go in and watch this procedure,
Yeah.
and it was Medtronic back then, and it was truly unbelievable the sort of what good looks like in this space from, can you talk a little bit about what it looks like and how this works?
Sure. Well, now where the robotic platforms are, you're asleep, anesthesia's knocked you out, there's a tube in your throat breathing for you. We put a scope down that. Now, historically, it's been a scope run with your hands. Looks like any scope that the GI doctor used on you or any other place, just one for the lungs. But now these robotic platforms, and again, they're all different in their shape and size, but it's essentially mechanically being driven, the scope through the lungs. But you're using a controller. So track pads and Xbox and Game Boy controllers. I mean, it literally, no offense meant, it looks like a video game.
Yeah.
The humor of this, of course, is that I was born in '72. I got an Atari in the late 70s. My father telling me that video games were a colossal waste of time, that unless I was going to be an Air Force pilot, what would I need hand-eye coordination for? The day I got my first robot, I sent a picture of my hands holding a controller and said, I mean, it was the ultimate, like, yeah, All those hours wasted playing Space Invaders were actually good for patients, right? So anyway, and then, the various bits, the technologies, without trying to dive into the various technologies, essentially what they do is they take your CAT scan. Now that CAT scan's a lot of data, and it's essentially can be built into a three-dimensional map of the inside of you. And that three-dimensional map can be superimposed basically on top of you and inside the computer that's running this robot, allowing the physician to drive and snake their way to know to go right, then left, then up, then right, whatever. Getting to that spot, using now for a lot of them incorporating various imaging modalities so that we can further affirm that we're right where we need to be, and then taking our samples and then having pathology in the room to confirm that we did get the diagnosis we need to get. Did we get enough tissue? And then once that's done, pull the robot out, put in our ultrasound scope to sample all your lymph nodes and make sure that it hasn't spread. And then we do all that, and then we wake you up, and then you go home. And so, and the thing is, the bronchoscopy, the complication rate is infinitely lower than the other forms. The bleeding rate's lower. So we have a safer procedure that now, with the current iteration of technologies, seems to be on par with the interventional radiologists. So in other words, we are able to be as successful as they are, but safer. And we stage you, so it's a complete procedure, right? Because unfortunately what happens a lot is I'll get a patient who will have a CAT scan, and on the assumption that it's tumor, it clearly appears to be advanced stage. And someone will do a needle biopsy. But that doesn't answer a question for me. They said, well, yes, it was adenocarcinoma, but we all kind of knew that in our gut. But what stage are they? So now they have to have a second procedure. And that, it never happens the next day, right? There's always, I don't care how efficient your place is, there's always a pathway to get you. So now more time's being wasted to get you the procedure that you need to stage you, that if I had just done that first, back then, if we skipped the unnecessary needle biopsy. So please, there's a lot of people that do bronchoscopy around the country. So those that are at home or watching, or have been told they have a nodule, or have a friend who's been told they have a nodule, please find someone who does bronchoscopy and does it well to do your procedure so that they can also stage you if it happens to be malignant.
Yeah, and we can definitely.
Yes,
Yeah.
please.
Yeah,
Right.
call us and we can help find one. It's so true. And like I said, having witnessed this, and this was the second robot? Was it? Or not, this wasn't even a robot. This was
Yeah, it was the
handheld
original
stuff,
super dimension, yeah.
Was fascinating, the fact that they can get to the tumor regardless of where it is in the lung,
Yep.
pull nodes from wherever they are in your chest cavity, and truly be able to say, this is what we're looking at, is game changing, and it's a one and done. It's not, to your point, all the back and forth. I don't know how many people in the room or online have gone and had either a fine needle aspiration or some other type of biopsy, and we're like, yeah, the tissue was no good, like we've got nothing, right?
Or didn't get enough.
Or didn't get enough.
Now, biomarkers and blood testing can help complete that story. You had asked me about that. That's a rapidly evolving area as well. Tumors shed, and they shed their DNA, and we can pick this up. And various companies, there's a lot of people in this space for obvious reasons. Blood complements tissue. Because in the end, I want to know if you have a mutation that's amenable to a targeted therapy. Is one, historically the other, amongst all the problems we've had with lung cancer, is that the approach has always been one size fits all. And I can guarantee no one in this room has ever bought anything one size fits all and had it fit, right? It never fits, right? It's always the dumbest thing you own. And so one size fits all had always been the historical approach to lung cancer, and we had the unfortunate outcomes to back up that experience, right? And so personalized management, like your tumor is different than the person sitting next to you. And in ways that we can quantify, not because you're different, your tumor's different. And that's what matters, because that's gonna dictate how we treat you. Drug X isn't gonna work for you. No matter how much it's the miracle drug of the day, it doesn't work on your tumor at all, and we know this. So you're not gonna get it, because why would we put you through something that has zero chance of helping you? But meanwhile, this drug, amazing for your tumor. So but you need tissue for that, and you need the blood to back that up. You need both. And so if you're gonna have a procedure, get the right one. And the goal is to be one and done. I don't want to bronch you again, ever. I want to do it once, be done with it, and then move you on your journey.
No, I think it's important, and I love how we sort of woven biomarker testing, particularly comprehensive biomarker testing. And this crew is very familiar with our firm feet in the ground stance on everyone should be able to have it. And it is so true. Like you mentioned back in the day, lung cancer was lung cancer. This is how it was treated. That was sort of it. And then it became, not only is lung cancer very personal to you, but in ways that we now don't think ever believed 15 years ago would be thinking about right now, right? And anyway, it's incredibly important. I don't need to go on that. But grab your mic.
Oh, sorry. That wasn't that long ago.
No.
And when it was, that's when we really started changing it.
Absolutely.
But it went on forever. And
and the sad part is it's still going on. And so the other thing, those watching at home, unless you've got definitive proof that the mutational analysis of your tumor, there's not even a clinical trial for you to be in, there's truly not a drug somewhere that we could give you because of just the nature of your tumor. In that situation, then when they say, all we have is platinum-based therapies, fine. But until that's been done, then there's still potentially something else out there for you, whether that's a FDA-approved drug or a clinical trial, if you choose, et cetera. But let me pause for a second. Has anybody really wondered why chemotherapies and targeted therapies and immune therapies are being advertised during Seinfeld reruns? Like, really? Like, why is that? I'll tell you why that is. It's because the physicians are not ordering the testing. And so they want the companies, who are obviously there to make a lot of money, want you to be proactive about it. This is why we have things like this. So it's funny, when I first started doing genetic testing of tumors in my bronch suite, we would make the diagnosis and we would take blood and immediately send it. And I got pushback from all these oncologists. They were like, you're not a cancer doctor. You can't send these things. And it's when I kind of puffed my chest out and I said, well, first of all, my patient, not your patient, not yet. My patient. So my patient needs an advocate, which is me, and I'm going to get them the results they need so they can arrive at your office knowing what mutations that you can then start to give them the correct therapy. Because one size fits all doesn't work. And once they got over their ego, they realized, this is great. So then once in a blue moon, like the blood won't get sent, just oops. And I get this like, where the hell's the blood? So like we broke them. We got them to understand that they have to have this. And the thing is, what everyone does need to understand about these blood tests, oncologists have their favorite ones. One company X versus company Y versus company Z. The way Medicare works, it will pay for one of these tests per company per patient. So if they want to send all 7 of them on you, which is stupid, but let's pretend, it's all covered. Now, they want to send it a second time, it's not. That's out of your pocket. But
So that's the importance of
yes.
getting it all done.
So, but wait, are you saying that, let's assume, and I'm kind of jumping ahead here, but I want to do it because it's relevant to this information. If you get a liquid biopsy, whether along with your tissue
Yep.
or not, and it's only sent to one company, if you need another one upon progression, you can
Right.
send it to another company.
So look, I'll give
and
you
it'll be
examples.
covered?
I don't know if I'm supposed to use company names or not. But
You
I'll-
can, go ahead.
Awesome. So when I do your bronchoscopy and I make your diagnosis, we send the Biodesics IQ lung right then and there.
Yeah.
And why? Because it only tests for actionable mutations up front. Not some research stuff, just the ones we can do today. And I get the results back before 5 days. And so by the time the final results come back from your pathology and you're seeing the oncologist, we already know. Meanwhile, all the other tests take 2 to 3 weeks. So you go to see the oncologist, you say, I have cancer, what are we going to do about it? And they go, yeah, we got to wait for some tests to come back. What do you mean you got to wait for some tests to come back? Well, I want to send this one. So my oncologists love a couple of the Biodesics competitors. Great, they send them. My hospital has our own molecular pathology lab. We run molecular analysis off of the slides we make in the Bronx suite. So you're getting, up and down, left and right proof that you have this mutation or that mutation automatically. But why not? This is how it should be. When someone's like, well, these mutations aren't common. Again, they are if you look. It's interesting because you can predict what percentage there should be of a mutation. So if you're a company that makes a chemo or a targeted therapy for it, you should expect X amount of prescriptions, right? You can, relatively speaking, predict for this. And all these companies were saying there should be this many people on my drug and there's this many people on my drug. What the heck? And it was this. Well, yeah, but it was lack of testing.
It was lack of testing because based on statistics, we
Yeah,
know.
no, I'm staying clear of the business side of this.
Yeah.
That's a whole different beast.
No, but you're not wrong, and I think, and I know folks again that have been with GoTo and following this programming and others recognize the importance of it, and I couldn't agree more, particularly in smaller community, more rural settings. This testing is not being done.
Right.
Like, period, hard stop. Forget the Bronx Suite and any of that fancy stuff.
Right.
Like, regardless of how they get the tissue, like
There's still a lot of one-size-fits-all happening in this country.
Yeah, and so it's why it's important to educate, empower, and then advocate not only for yourself but for others. I want to.
That's why, I'm sorry.
Mike.
Sorry. That's why it's so important to teach the patients.
Yeah.
100%.
Yeah.
For them to ask and
100%.
make sure
To
they
ask.
get the right,
Absolutely.
100%.
Absolutely. We kind of went down a little rabbit hole, and we'll touch probably on it.
Yeah, but it's a time of diagnosis, so it's equally as important.
It is important. It is very important. One of the things, we touched on CT scans and PET a little bit, and when you and I were talking prior to this, you were very, very passionate about quality CT scans.
Oh, yeah.
And this is relevant at diagnosis and
everything in between.
Progression. Yeah.
So there are guidelines on how CAT scans should be done, and they're not followed. A CAT scan, as fancy as it is essentially, they're taking slices of you, but there's a lot of averaging going on, right? Higher resolution, better. I get a better look at your lung, right? That means lots of different things to lots of different people, but high resolution should be thin slices, continuous. In other words, when I scan you, I should have about 360 pictures of you to look through. And that takes a while, doesn't it? But what happens across the country frequently is you're getting what are called 3mm cuts. So there's only 120 pictures of you. Or worse, there's still places that do 5mm cuts. 5mm cuts is the equivalent of whatever TV you have on the wall right now. Think of the TV you had 50 years ago. That's what you have, that's what your doctor's looking at making decisions about you. And here's what ends up happening. When we're still dealing in the stage of we don't know what you've got, you get patients who shop around on CAT scans. And so they come with a 5mm cut scan, a 3mm cut scan, and they finally get a good scan. And someone says, yeah, your nodule went from 4mm to 5mm. No, it didn't. You had a lousy scan followed by another lousy scan, someone going like this, and that's 1mm growth is not growth. Or maybe it is, which is why you need a real scan. By the way, it's not more radiation. You hear high resolution, like, oh, they must be really zapping me. No, it's everything about detector quality. It's about the quality of the scanner. It's whether or not that center has bought a CT scanner in the last 5 years, or 10 years, or 20 years, right? If you pull up to your hospital and that CT scanner's on a truck, go someplace else.
So I guess that was going to be sort of my
Not the PET scanner. PET scanners are very expensive, and the mobile ones are fine. But CAT scanners, move on.
Yeah. And I think that's sort of the bigger question that I would imagine a lot of people would have is how do they know outside of the truck? How do they know and what should they be asking?
I want to know if my scan's going to be thin cuts with a continuous intervals, meaning like the deli, slice, 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 not slice, skip halfway down the meat, then slice again, because that's the other definition of high-res cuts. They do one thin cut, and then jump midway down you, and do another thin cut, and then jump midway down you. The snapshots of you.
And they've missed all that.
Yeah, they miss everything in there, right? I mean, and remember, this is more on the diagnostic side of whether your nodule's concerning. Let's go the different direction. Now you've been diagnosed. Now we're trying to judge your response to therapies. Now we're trying to judge whether or not you're developing complications from therapies. If you're going to get radiated, why not get the most bang for your buck? And quite literally, less radiation with a higher quality scanner. Ironically, it's actually less zap. Sir?
Yeah, can you say a few words about contrast?
Yep. So if you do high resolution cuts, so I never order contrast on any of my CAT scans. I've been doing this now for almost 20 years. The only time I ever order contrast is if I'm worried there's a blood clot, right? You do need that for blood clots. Or if someone's coughing up blood and for not an obvious reason and you need to see the vasculature. But if all I'm trying to do is follow whether a nodule or follow a progression of a tumor or lymph nodes, a high resolution scan lets you see all of these things without IV contrast. So your patient doesn't have to get poked, and and God forbid they start to have some level of kidney disease, then we can't easily give you contrast. God forbid you're allergic to it. Now what am I supposed to do? Right? You're in your mind think you're getting an inferior scan. Oh, I can't get that contrast. I'm allergic to shrimp. Right? No, you don't need the contrast. Right?
I think
it's an iodine allergy, right?
Yeah, I think this is such an important point because quite often, and I know, and Larry, I don't know if you or anybody else, I don't mean to call you out all the time. You're sitting in my line of sight, but quite often, particularly a follow-up scan, somebody's in treatment and they asked, well, two things, and I know this probably runs in the med-onc sort of space, but question number one, CT or PET, and I know we're going to talk about PET in just a second, but CT or PET and how often? And I know and you and I had talked about the contrast thing too, and I think that a lot of people are going to be very surprised to hear that, and some people might also be like, what the hell's contrast? I've never even had that.
So if the scan's done right, you don't need the contrast. And so without some certain scenarios you might. There also may be, if you're in a research protocol, there may be a scenario where you need contrast because they need some specific technical issues. So again, it's not that no contrast ever, but majority of the time it is not needed. And what is it? It's radio opaque, right? So the lung is mostly air. So the lung looks black on CT and dark gray. And you want to be able to highlight other structures, and vessels will look a different shade of gray. But if I make them white because of contrast, then it's very obvious what's a vessel versus what's not a vessel. But if you have a good resolution scan and you're scrolling up and down, and this is all you do is look at scans, so you don't need it. I make this statement because I was trained by the gentleman who wrote the Fleischer Society guidelines, and he taught me how to read CAT scans. He's retired now, but Heber McMahon is arguably one of the best thoracic radiologists in the world ever. And if Heber said I don't need contrast, then I don't need contrast.
Because you brought it up, can you explain Fleischer?
And you had a question, I'm sorry.
Oh yeah, Rick, sorry, go ahead.
So on the contrast thing, I don't really understand how it works. So does that make it easier to read? Does it make more difference between something and something else? Or what is the real value add of contrast in the first place?
The contrast is needed when you need to definitively see the vasculature. So if I'm worried you've had a pulmonary embolism, I have to give contrast because I need to be able to have your blood vessels filled up with this white stuff and see the filling defect, the clot that's sitting in there. If you're coughing up blood, but there's no reason we think you should be coughing up blood. There's not a tumor in your airway. Why is he coughing up blood? So then you do that because that highlights all the vessels, and then you see some weird vessel in the area where you maybe got radiated and it's twisted and it's, you can even sometimes see that it's leaking. Not often. So that'd be the other reason to do it. But if all I'm trying to do is follow a tumor that has been, is undergoing chemotherapy, and then is it shrinking, right? Every 3 months they're going to scan you. Is it shrinking? Are you responding? You don't need contrast for that. You can see it. You can see it shrink. You just measure it.
Does it help at all with any new stuff that could happen in some other place?
Not really.
Like, why would they add? What's the downside to it?
Allergic reactions, damage to your kidneys. You need an IV. You got to get blood drawn beforehand. Extra cost.
I've had it many times. I've also had it not times, and MRI always has it.
MRI is different.
Yeah, MRI always has it. And CT, it's some of the times, and of course we always have PETs, which are tons of fun too.
Right.
I want to jump into PET.
Okay.
Let's jump into PET.
So PET's an interesting discussion. So let's take it from the range here. So for those that are listening and watching who are not yet either, they've been told they may have a diagnosis, or they've been told they have a diagnosis, but we don't know what stage they are. So PET scans get done as part of that workup in some places. So the thing to remember about a PET measures things that are metabolically active. What does that mean? So it means your brain's going to light up. For most of us in the world, there's something going on upstairs, right? Meaning you're thinking, so you're using they're injecting radioactive glucose, right? Sugar. Your brain sucks down a lot of sugar. Your heart lights up. Your heart sucks down a lot of sugar. The rest of your body, generally speaking, isn't doing much work at a given moment, right? So the brain and heart light up, and everything else should essentially be, quote, cold on PET scan, because it's measuring the accumulation of this radioactive glucose. So for those that had a biopsy-proven tumor, the tumor will light up because we know it's a cancer. It's a metabolically active thing. It's growing, so it's sucking up a lot of sugar. So the PET scan will light up there. But if you don't know what you have, if I do a PET scan on anyone in this room who has pneumonia at the time, like true pneumonia, it will light up. Did you know that if you just, right before coming in, show me your ankle. If we did a PET scan on you right now, your foot's gonna light up because you have an injury.
It actually feels hot.
Yeah, exactly. You have an injury though. Yeah. If you get kicked on the way in or banged your elbow on the way in, your elbow is gonna light up, right? So in other words, a positive PET scan doesn't automatically mean you have tumor. Now, in some cases though, it unfortunately is very useful. We've proven you have a malignancy. We're worried it's advanced stage. The PET scan can help to clarify extent. In other words, it finds areas in the bone that have lit up. And there's no reason those should be lit up. So that means, unfortunately, that it has spread to the bones or the adrenal glands or things like that. Mm-hmm. So there's a value to a PET to sometimes, in some scenarios, spare a patient from a longer drawn out procedure when we already clinically look like it's advanced stage. Go get tissue, go prove what's going on so we can get this person started on tailored therapy. Now, the role of repetitive PET scanning, that's definitely a question more for med-onc. Mm-hmm. My always fear about or concern about PETs when decisions get made solely based on PET activity. When a PET's negative, that's very reassuring. Even if something's cancerous, because PETs can be negative and still in the setting of tumor, but it means it's a very slow growing tumor. So we do have time on our side in that situation. But I live in Chicago. Histoplasmosis and blastomycosis are endemic in our part of the country, and it's pretty broad. Those light up like a Christmas tree on PET scan, and they're a spiculated, nasty-looking nodule. They look like cancer.
Why is that?
Why is that? Because it's metabolically active. It's a fungal infection.
Okay, but I mean, is it more in Chicago? Or?
It's in anything that drains along the Ohio and Mississippi River valleys. So it's a good chunk of the country. You guys get not so much up here, but Southern California and Arizona, New Mexico gets all the coccidiomycosis. And so in Chicago, though, all my people leave for the winter and either go to Florida or Arizona. So they bring cocci back to where I'm at. And my point being is I've had plenty of people come to see me who said, my primary ordered a PET scan, they've told me I have lung cancer. I said, well, who did your biopsy? They said, well, I haven't had a biopsy. I said, well, you may have lung cancer. I mean, it's on the list, right? But there's a long other things on that list, which is what we're gonna go prove or disprove. Now, if the PET scan was stone cold negative, like no activity, that's part of that discussion of, do I need to do a biopsy? Maybe I don't. Maybe it's a questionable nodule. Maybe your medical health makes doing a biopsy a challenge, and a negative PET scan would argue whatever this is, it's not metabolically active. Remember, the lung also scars. Sometimes for a lot of people, the CAT scan that found your cancer is your first CAT scan, typically, right? So and someone will say, I see a patient, they'll say, well, why do I have this thing in my lung? I'm like, well, did you ever have bronchitis or pneumonia? Oh yeah. I'm like, oh, there it is. Yeah. The lung scars like your skin. We all have cuts and wounds from everything. Your lungs is no different. This is the negative of how good CAT scans are.
You can find it at the airport.
That's right.
Yeah.
That's right.
I think that's really. So I do want to get into the treatment and management part because I
Sure.
think that's going to be relevant.
But real quick,
go.
if your oncologist says I need a PET scan every 6 months for whatever reason, I'm not a medical oncologist, so I wouldn't
Yeah.
fight that one. I
Yeah.
guess.
Yeah.
You know, they use it to gauge response to therapy.
But I think sort of the moral of this upfront part around diagnostics, in particular, there's sort of the trifecta of the three, right? Appropriate biopsying,
Yep.
including lymph nodes, appropriate CT scans with your thin cuts,
Yep.
and a PET scan. And with those three diagnostic tools, you can come to.
Well, there's even some other blood work too, right? So there's the serologic work for these infections. There's the Notify test that Biomarker does that helps to quantify a nodule's risk for cancer. Because again, not every nodule automatically needs to be a biopsy, right? It all depends on what's the probability that it's malignant. What's the safety factor involved in making your diagnosis? So.
Yeah. Does anybody have any questions before we move into treatments? Yeah.
Yeah, do you have anything to say about ground glass?
I got tons to say. How long do we have? so ground glass. So in an undiagnosed person who's been told they have a ground glass opacity, so that's a different beast. So far, all I've been talking about is nodules, solid, right? Think marbles, depending on the size of the marble, but solid things that should not be there in the lung. A ground glass opacity is a radiographic description. So it's the way the radiologist describes what they see on this CAT scan. And there's a long list of possibilities there as well. Ones that persist, but don't grow. So they can scan you again months later, it's still there, it's still 9 millimeters, it's not any denser. They scan you a year later, it's 9 millimeters, it's not any denser. The guidelines tell us we have to watch this for 5 years before we can call it stable, because every one of these is potentially either a precancer or an extremely slow-growing form of adenocarcinoma. And so it enters into a complex discussion. And that's what I tell people. So let's envision two scenarios. You're 50 years old, you've never smoked, you have a ground glass opacity, and it's gotten slightly bigger. I'm extremely worried that's an adenocarcinoma. If it's gotten denser at all, it's almost guaranteed to be an adenocarcinoma. So we need to do something about it. Now, the same lesion, but it hasn't changed. It's not getting denser. But you're 85, you've had 2 heart attacks, a stroke, you have diabetes, and you have heart failure. And on the last scan, it hasn't grown, and on this scan, it hasn't grown. The probability, even if I could tell you, no debate, that's the start of a lung cancer, but a slow-growing form of it, these adenocarcinomas in situ that are this unique tumor biology, for lack of a better word. Should we put you through a procedure that, for something that arguably, statistically, is never going to harm you? That's a different discussion. So ground glasses are never a boom, boom. It's the whole picture put together. But ground glasses that are changing, always concerning. Bigger, definitely concerning. Denser, extremely concerning. So in your ground glass, next year it went from 9 millimeters, still 9 millimeters, but now it's called the Hounsfield units. It's denser. They call it a mixed ground glass now, or whatever word the radiologists will use. That's extremely concerning. That should definitely get a biopsy. And in some cases, potentially just be resected. Clinical parameters aside, coming again back whether someone should have a biopsy or not.
Okay, yeah, so doubled in 10 years in size.
Doubled in size in 10 years, but without any increased density. So challenging, but the argument is that obviously it's almost assuredly an adenocarcinoma. Obviously not 100%, but almost assuredly. But its biologic potential for malignant spread seems to obviously be quite low. And so then that becomes a very hyper-personalized discussion of, this is similar for the men in the audience of, at some point, the prostate cancer. At what point am I going to do more harm to you to cure you of something that was never going to harm you? And there is no right or wrong, right? the buzzword in medicine, shared decision making. It's a polite way of saying it's on both of us. But what it really is, and this is why, if I can think of 1,000 more reasons to love this organization, is to arm people with information so they understand the purpose of a shared discussion. That unfortunately, I don't work in the world of absolutes until I take a biopsy. Then I've got absolutes. But before I do a biopsy, a ground glass that's growing, almost assuredly, but you'll never get me to say 100, right? Not until a biopsy is done. Whether we should do that biopsy debate is dependent on a lot of things, right? And it goes the other direction too. As I have patients come to see me, they have a small nodule, exceedingly small, but they're terrified, understandably. But I reassure them and say, look, based on the probabilities and whatever, there's literally a 2% chance that this nodule is malignant. Not 0, but definitely not way up there. But the pneumothorax rate, popping your lung from these procedures, is 2%. So there's a equipoise between me harming you and helping you and all these other people that we watch and wait. And by the way, watch and wait doesn't mean do nothing for you. It means get a follow-up scan a couple of months later. And when that 4 millimeter, 5 millimeter nodule becomes 6 or 7, that changes the discussion, doesn't it? When it doesn't change at all, aren't you glad that we avoided poking you and the other 98 people that, that we sat on? Right? There's that. I will jokingly say to a lot of my patients, part of my job is to protect you from people like me. I do biopsies for a living. Are you kidding? I love to do bronchoscopy. This is what I do for a living. It's fun. I want to do it, unless you don't need it, right? And that's why I kind of jokingly say this. Like, the healthcare industry is built to biopsy you, right? And occasionally it's very important to put the reins on this.
And,
At least that's our clinic.
Mike.
Use your mic. Use your mic.
Wonderful that you have that attitude. It really is.
It's
Not enough people do.
If you need a biopsy, we're going to go get you. But if you don't, I don't want to touch it.
Yeah. Pat, grab your mic.
Oh, sorry.
I receive part of my care at Palo Alto Medical Foundation and the other at UCSF.
Uh-huh.
So, the medical oncologist is at PANF, and he chooses PET scans. And my oncologist says, why are you putting yourself through that? And I said, well, why not? Don't you want the best pictures? And
Well, so it's funny though, a PET scan's not the best pictures.
pardon?
PET scans have a low resolution CAT scan attached with them.
Really?
And they do. And remember, metabolic activity is not automatically tumor. If you've been radiated,
Yeah.
that's a burn. That's going to light up on PET scan.
Okay.
At least in the period of time right around.
might
Now,
listen to
you're
him
3
more.
years out, that's a different. Your CAT scans change some. This is an area of open debate, so I will not, that's why I said, like, if the oncologist wants it, there's potentially a rationale for it. I'm not, it's not something that I can vehemently defend the way I can other parts of my practice, where I will tell you, people who say the opposite, I will tell them how wrong they are. This one, I'm willing to concede.
Okay. Because I thought PET scans gave better pictures.
No.
And yes, he said, well, usually, but you don't need the extra radiation.
Well,
I'm
it's not
only
even
getting them
that.
every
PET scans
6
also,
months.
anything smaller than a centimeter, PET scans really don't have good resolution. So unless they're following something large, like if you have some 8 millimeter nodule, and they say we're going to get a PET scan to further evaluate that, and it comes back negative, it doesn't mean squat to me. It's too small to be seen. It doesn't mean it's negative. To the limits of the test, it's negative. If your 3 centimeter thing is negative, it's negative.
Okay. Thank you.
You're welcome.
Michelle, just check in online. Are we good? Okay, you have your mic.
Do the newer robotic bronchoscope, that was nice. Can they successfully be used to biopsy a part of solid GGO?
Yes. Sorry, can you use the new robotic platforms to biopsy partially solid GGOs?
Ground glass.
That was actually the first case I did with the new device. So, first in the United States. So,
This has all been incredibly insightful. I actually have learned a lot.
I'm sorry.
I mean, I knew most of these things.
I know you
No,
did.
I'm teasing.
That means I talk too much, though. I'm sorry.
No, I actually did, especially when talking about CTs and PETs and the importance of it. I think that's very relevant at diagnosis, and I think it's very relevant when we're thinking about maybe a follow-up scan showing something and whether or not it did or
Yep.
it didn't, and how we either need to continue to follow it and or rebiopsy and the like. But now I do want to jump into outside of that upfront role
Right.
that you play, some treatment
Yep.
on not only on managing disease, but also managing symptoms.
Sure. So let's actually, and this is yet another reason to have a pulmonologist. But also, before I even say that, let me back up. The biggest thing that I see frequently with any cancer patient, and not just lung, is understandably it becomes the primary focus, as it should be, but to the detriment of everything else in their health. In other words, so they stop their cholesterol medication, they stop seeing their primary care doctor, their blood pressure is out of control, their diabetes is out of control, whatever, right? So you go through all this with cancer, come out the other side, and have a massive heart attack because you ignored the rest of your health. Or get colon cancer because you didn't get a colonoscopy. Or stop getting mammograms because I have lung cancer. You can still get breast cancer, right? I mean, it's so the whole reason why then from my neck of the woods is obviously lung cancer can happen, smokers, non-smokers, current smokers, ex-smokers, never smokers. But if you have any amount of smoking-related lung disease, it needs to be treated. Like, in what world would you be continuing to be short of breath from something that I have simple inhalers for, right? If the tumor is compressing an airway and is significantly making it hard to breathe, and they haven't even started therapy yet, they're going to radiate chemo. Let us get in there and dilate the airway. Let us stent the airway in some cases. Let's let you breathe better while you start down whatever pathway. Are you doing pulmonary rehabilitation? Which is basically a formal way of saying, we're going to make you exercise, and it's going to be covered by Medicare. And you should, if you have lung disease, like obstructed lung disease. Don't neglect the rest of you. Because no matter what you go through, whether it's a targeted therapy or chemo, radiation, immunotherapy, or surgery, your body's going to take some level of abuse, which is a wide variety. So get your body as ready as possible by staying on top of everything else.
So there's something, like most people don't have sort of like a baseline pulmonary function test, right? That they're kind of kicking off from, but
they should.
They should. And that's what I was just going to say. How important is it for people diagnosed with lung cancer to get even that baseline and then follow up to see?
So if you've been a smoker at all, you should totally get a pulmonary function test because we've got to know if you have obstructed lung disease. If you're a lifelong non-smoker and you have lung cancer, the pulmonary function testing is less vital in the sense that unless you've had significant secondhand smoke exposure or industrial exposure, et cetera. But it's only necessary if some of the therapies that are going to be employed are potentially pulmonary toxic. But if you're short of breath, you say, when I go walking, I'm short of breath. But there's a long list of potential reasons. Starting with the fact you might be anemic.
Yeah.
Right? You may have COPD. You might have heart disease. You might have thyroid disease. I mean, the list goes on. There's a long list of reasons. Never just assume it's your lungs, but go see the pulmonologist so we can say, some of the happiest times I get to say is like, you don't have lung disease. Yes, you can't breathe. Here's why. We go figure out why, but it's not the lungs. Frequently it is the lungs, of course, but let us do something about it. As part of your cancer, you may have a large pocket of fluid inside the chest cavity, squishing half your lung. You're not breathing with a full deck. Let's get the fluid out of you. We drained it. It came back a week later. Okay, well then let's do a different procedure to keep it from coming back, right? Because draining you once a week is not a solution, right?
Yeah.
But we need to be able to make sure that at all times we're dealing with your breathing. If you're going through your therapies and now you're having more trouble breathing, and you just go, well, but I've been through a lot. They said sometimes this can cause problems, so that's probably all it is. Well, except there are significant amounts of pulmonary toxicities from some of the drugs. You can definitively get what's called a pneumonitis from some of the immune therapies. This matters, because if you're having a really severe reaction, we may have to abandon some of the therapies you're on, depending, right? If you're developing a new pleural effusion, we need to get that fluid out of you. If your tumor has progressed and is obstructing an airway, let's deal with that. There's so many different things that we can do to help you breathe better. That's why earlier at the beginning I said palliative. Palliative to me, like, it is a word that I wish we could come up with a different word that wouldn't have any bad connotations. Anything I can do that controls symptoms, that gets lumped under the palliative category. How's that a bad thing? I want you feeling better. That's always good.
So what about the patient? Because quite often people will have surgical options.
Sure.
So they've had a lobectomy or a pneumonectomy. So either part or all of,
Yeah.
right?
They're missing lung.
That compromises lung function.
It can, sure. And in fact, part of the evaluation for surgery is do you have enough lung capacity that when we remove X amount of lung, how's your breathing going to be? It will potentially be diminished from where it was, but when someone has been told, hey, you're early stage, but you can't get surgery because of whatever, it's usually almost always related to the degree of lung disease they have, usually COPD or emphysema. But the inhalers and pulmonary rehab can improve this. We like to call it prehab. You should be, before, they say, all right, you need surgery, it's gonna be in 3 weeks. That 3 weeks, you should be very active. You need to sort of, rewatch Rocky and hit the gym, and get yourself going. You will do better with surgery.
Yeah, I know. I don't know where Bonnie went. Okay.
Excellent.
Rude. I'm teasing. So, so we talked about airway stenting. We talked about PFT.
We have ways to ablate tumor too. We've got various energy-based things there's multiple options, and not everybody's got it. Not everything's an option, and there's multiple studies going on other ways to try to minimize tumor. That's the point, though, that until someone says no, there's nothing I can debulk, there's nothing I can stent. You're on the best inhalers. You've done the pulmonary rehab. Your heart is good. I'm still very short of breath. Then I don't have a better answer, but we've at least checked all the boxes. Because again, I'm interested in you feeling better. No matter where you are and what you're going through, you still deserve to breathe better and feel better along the way.
I think that's a great sort of segue into, particularly when traveling to high altitudes or flying long distances.
Yeah, it's challenging.
An altitude test. Why is that important?
I mean, so when you're up at 36,000 feet in that plane, you're not getting the same partial pressure of oxygen as you get down here. And you may discover, unfortunately, at 36,000 feet that you needed oxygen. That's not the best time to discover it. If you're someone who needs oxygen with altitude, you can fly with oxygen. It's just like all things in this world, paperwork and logistics. Don't expect to show up, an hour before the flight and say, oh, by the way, I need oxygen. You're not getting on that flight. There's, and every airline, of course, has its own form and requirements. But it's easy to do. I've got, again, remember, as a pulmonologist, I've got a ton of patients with emphysema, COPD, and other diseases that need oxygen all the time. That have nothing to do with malignancy. We do this all the time.
Yeah, and I think, and I'm sorry Bonnie had to leave because I know this is one where she found out the hard way the challenges she had with altitude. She was not even on a plane. She was in Boulder, Colorado at one of our
Mile high
events.
at least, right?
Yeah. And of course, because we all know she can't stay still, she was running all over the place and all of a sudden was just not great and had to be taken away in an ambulance. Am I right, Jen? Yeah, and that's when she realized her O2 sats were like below 70. It was not good.
Yeah, no, it's you will feel obviously awful with low saturations, and obviously we have therapeutics for it. Now, I'll go ahead and dispel the first myth that usually comes up as soon as oxygen gets mentioned. I will hear it pretty much every day in clinic. Well, I don't want to get dependent on this stuff. Little news flash: we're all dependent on oxygen, right? And in fact, so you're already dependent on it, so embrace it. But number two, you don't make yourself stronger by robbing yourself of oxygen. You actually make yourself weaker. You're asking your body to do twice the work. Why would you do that to yourself? I understand no one wants to wear oxygen. It is a visible outward sign that you're ill. I get that. But if you're going through everything else to propagate your health, you're going to skimp on this one, right? I mean, really? Like, let's keep you at maximum capacity, right?
Agreed. Questions? I'm being mindful of time, and I know we're right at it. But just I do want to.
I can go longer. My flight's not till 1:30 in the morning.
PFT, altitude, pulmonary rehab. We did it. Trials. So we touched a little bit on trials. Talk a little bit about what's going on
Yeah.
in
so,
your world?
So there's, oh my gosh, in my world, there's tons of trials, especially obviously on the therapeutic side. The goal of trying to do, I mean, take your pick. Obviously, cure is always the first goal. If we could find a way to cure lung cancer from the inside, no surgeries, no radiation, no, amazing, right? That is the moonshot, and that's the goal. And we'll get there. It's going to take time. And there's a lot of bumps along the way. It both needs to obviously prove it's got to work, it's got to be safe, right? I'm not doing any good if I can say, well, I can cure this many people, but I harm this many people. No thanks, right? And truly harm. And so, but there's also at the same time a lot of different therapies being developed to sort of, for lack of a better word, prime the immune system, right? You've been hearing about immunotherapies. Tumors are very good at hiding from the immune system, and your immune system views tumors as foreign, or it should. So if you can go in and sort of disrupt a significant amount of tumor by different and multiple different methodologies, in fact, it's one of the things I'm lecturing on in Thailand, the idea is you kind of expose it all to the immune system and get a more revved up response. Or if you've been responding to immunotherapy and then starting to lose response, maybe this lets us recharge things. Again, all of these are under investigation, being looked at as a possibility. But the fact that we're even saying this is part of the awesome news of what's going on in lung cancer, because this wasn't talked about at all a decade ago. Therapeutic what? No, not at all. Immuno what? Nobody, it's like, not at all. So clinical trials, people's involvement with the clinical trials, obviously a very personal decision. You are, without a doubt, volunteering, right? I mean, there's always some trials will offset travel costs, some trials are gonna be a nominal, it's never worth the money, right? You're only doing it because you're interested in what it's discussing, or from an altruistic perspective, you're wanting to advance the field. And what I always remind everybody is that where we are today only happened from clinical trials, and where we were a decade ago happened from clinical trials. So we're all standing on the success of clinical trials and the volunteer spirit of the people that signed up for it. Now, that being said, you're still signing up for something that is considered experimental. And there are various levels of trials. So there's like uber experimental to something that like pretty much everyone's sure it's going to work. We just got to prove it last, right? So phase 1 to phase 3, and you can choose to sign those up. And also the other thing too is trials have rules and requirements. You may be the most perfect candidate for the trial, but the cutoff age is 65 and you're 66. Sorry. And there's no getting around that. These are trials that are ultimately going to the FDA. Trust me, the people running the trials really want you in the study. They would love to have you in the study, but they can't. They'll basically get dinged and it'll ruin the study. So it's not that someone doesn't want to help you. We're not allowed to. And as I always remind people too, when people desperately want to be in a trial and then for whatever reason can't get in, and understandably very frustrated by that, not everything works. And in some cases, trials show that the thing is actually worse. So in some cases, not getting in the study might have helped you. And when everyone understandably doesn't want to be in a placebo trial or doesn't want to be in a sham-controlled study, sometimes placebo does better. And remember, frequently, almost, unless it's phase 1 trials, like a lot of the phase 3 trials for the various targeted therapies, it's standard of care plus. So you're not getting nothing. You're getting what everyone gets. The study is you're either getting the sugar pill, quote, quote, sugar pill, or the drug to see if it makes a difference. And then it gets monitored along the way, because of course, no one talks about the trials that get halted halfway through because it turns out the drug's ridiculously toxic.
Yeah.
It doesn't work at all.
Yeah.
Right? Those don't make the press.
Yeah. I think it's interesting. We've done a lot of talk about clinical trials in here, and a huge kudos and thank you to those who have participated, some of whom are in this very room and I'm sure watching right now. Because it has advanced the field. And there are some instances where clinical trial is the best decision for you based on where you are in your journey. But I think this points back to, and I don't know if we've sort of talked around it, but I don't know if we talked specifically to it, the importance of a multidisciplinary care team. Yep. Everybody having these conversations about you, personalizing whatever next step or action is to you. We talked about how lung cancer is not what we thought it was even 15, 20 years ago.
Right.
But it's really become this series of rare cancers. It's not just 225,000 people in the US are diagnosed every year with lung cancer. It's like, wow, we have really broken it down into many rare diseases, and there's a lot of personalization that goes along with that, and I think.
Well, and the reason you need the multimodality, because you only know what you know. In other words, I will freely admit, I have no idea what new targeted therapy came out last week. I'm sure one did. I don't know. I don't prescribe them. I'm not a medical oncologist.
Yeah.
I try to keep up, but there's only so much I can keep up. But I guarantee you my medical oncologists are not keeping up with the latest and greatest therapies that we offer on the bronchoscopy side or the clinical trials that we offer there. And the radiation oncologists have a whole bunch of new different tips and tricks and techniques and things they can do, et cetera, et cetera. The point being that why you need multimodality, this field's gotten wonderfully complicated, which is great. It's an awesome problem to have. It used to be ridiculously easy to do lung cancer because you didn't have to know anything.
Yeah.
And so this is a wonderful plethora of riches. But that means then why you need a squad, because you want to know what your options are, especially if you're ever at that stage where they're telling you your tumor's progressed, I have no other therapies for you. Until you've been evaluated for clinical trials, if those interest you, been evaluated for any bronchoscopic-based trial that might prime an immune-based response, until radiation oncology doesn't talk about some of the things that they've got under their belt, until we've done a mutational analysis and see that there's not some study that just launched. Because remember, maybe you weren't a candidate for some drug 2 years ago because it didn't exist, right? It was an early phase trial, but now it's in its phase 3 trial. And now your mutation's good for it. Go, 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 right? Again, and you may not be a candidate, you may not want to, but until you've exhausted the possibility of studies and other things, when someone says, I don't have any other treatment options for you, then you should be looking. And then if that's not there or those don't interest you, then unfortunately that's the stage you've reached at. Okay, but you at least could comfortably know that there's nothing else that you didn't try.
And you've made the right decision.
And you've made the right decision for you.
Yeah, I agree. So before we get into sort of takeaways and closing remarks, I quoted you on our call, and I'm going to read it.
I want to read it.
And it was very simple. I mean, obviously, I adore Kyle and his approach and how he can bring levity to what is a very serious and confusing diagnosis for people. Because I think, well, you guys all know, at least in the room, the levity that was around at the time of my mother's diagnosis through her treatment and still today was so needed and helpful and allowed the hope in the room. So anyway, this is what Dr. Hogarth said. He said, people with lung cancer have compromised lung functions, but sadly, a lot of times, a learned helplessness.
Yeah.
You can and should keep doing all of the things that make you happy, and a pulmonologist can help you do just that. So, you shouldn't find yourself limitless without first finding out whether or not there is an option to get your quality to a place where you can go do all the things that you've always wanted to do.
That's right.
So I hope you don't mind that
No,
I read that.
but it's true. It's true.
Yeah. And I just want your sort of closing remarks. And what out of this whole conversation tonight, what do you hope people take away?
Ask questions and be an advocate for yourself. Recognize that, I always make the joke, so if you've ever been to the University of Chicago, we're convenient for nobody. They managed to build a hospital that is impossible to find and get to, and is far for everybody in a city fraught with ridiculous traffic like this one. So, so then why do people bother? It's your health. If the doctor down the street, it just isn't cutting it for you. And it doesn't mean they're not a good physician. It doesn't mean that everybody else in that room is having a great experience. Maybe you're just not jiving with them. I mean, this is a person who's advocating for your health, or should be. And if you don't feel that connection, look someplace else. Your guidance for what they should be doing for you, stay up to date on your reading. Make sure that you like this person, that they're listening to you, or they're responding to you. And if they're not, find another one. There's definitely more than one cancer specialist in the Northern California area. I'm pretty sure, right? And there's definitely more than one pulmonologist. And someone's like, yeah, but it's like on over there. And you're like, oh yeah, but you're not going daily, right? If you're going daily, I get it. But come on, this is your health, right? This is the one time convenience is not the top priority in your decision tree. It should be in there. If it's equal, then go closer. And just because they're close doesn't mean they're bad. It actually, sometimes, that's awesome, but boy, that should not be your only criteria.
Yep.
Is that fair?
That's fair. I think that's fair. I think that's fair. So takeaways from me, and obviously I wrote these down before. I didn't put my own self on the spot like I just did Dr. Hogarth. But everyone diagnosed with lung cancer should have a pulmonologist on their care team. And I feel like there's a period hard stop that comes after the end of that sentence. There are options for people with compromised lung function, and people with lung cancer have compromised lung function for one reason or another. Novel treatments and trials are available. But
and not just oncology, pulmonary as well.
Yeah. And there's continued need for innovation. Like we talked a little bit about the robot and all the crazy things that I can't wait to learn more about that they can do now with that. But I think those for me are my big takeaways. Up next, Dr. Jonathan Reese and Megan Daly from UC Davis.
Great.
A medical oncologist and radiation oncologist. They've both been here separately before, but they're coming together to talk about how they work together. So we're taking two more people from this multidisciplinary team to talk a little bit about how they work for you. Gathering Hope is, and that's on October 17th. The next Gathering Hope, thank you to all of you. And I know I'm speaking to people who are watching either live or post live later, as well as folks in this room. Thank you so much for participating in that program. And for those of you who don't know, we started that 18 months, 2 years? Was it 2 years ago now?
Wow.
2 years this month. And so Michelle oversees that along with Miranda Goff, who's another one of our colleagues out of the East Coast. And it's really created that, remember you guys, the around the room sort of thing that we used to do here? It's the around the room. So anyone who wants to engage can engage in that. Prior to that, it was just the people who got to be live in this room or virtually, wherever we might be doing this meeting from. But it sort of left out all those other folks. And I just can't say how much I appreciate your attendance and how wildly successful it has been, and the feedback that we've gotten, and how much people are loving it and how much it's growing and all the things. So if you have not participated, October 10th, 5 p.m. Pacific, I want to give a huge, huge thank you to my friend Dr. Kyle Hogarth for flying all the way out here from Chicago on his way to Thailand. All of you watching live or post live, Penn Media, as usual, for coming in, setting up, breaking down, getting us all ready for this so that we can bring it to anyone, regardless of where they may be in the world. Appreciate you. Go to staff. There's a couple of them here. Thank you. And for all of those that aren't here, of course, I need to give a huge shout out to our supporters: Amgen, AstraZeneca, Bristol Myers Squibb, Daiichi Sankyo, Eisai Foundation Medicine, Genentech, Merck, Mirati Therapeutics, Novartis, Novocure, Regeneron, Sanofi, and Takeda. Without their support, we couldn't continue to bring this to you. And I think we're going into our 13th or 14th year of the Lung Cancer Living Room now. So
awesome.
we're really excited. We can't wait for folks to come back and help us fill up this room like it was pre-pandemic. But thank you to all of you who continue to show up live each and every day. The San Francisco 5K. So this is for those in the room and those watching local. Yeah. Jen, do you want to say something about the San Francisco 5K? Well, I don't know what time it starts or anything. Sorry.
Yeah.
Get a mic. Rick, will you hand Jen, or somebody hand Jen? Oh, Katie, go ahead.
Yeah, you and your boot.
I know.
Nope. Hi. Okay. Hi, everybody. Katie Morello, manager of event operations. So San Francisco 5K at 9 a.m., Lake Merced. Looking forward. It has a great turnout. We're anticipating over, hopefully, 400 attendees.
Nice.
Shout out to Team Jill in memory of Jill Costello, who's we all know his legacy here. So they have over 125 participants on their team. So,
Lord, that's awesome.
And so far, we've raised over $100,000 for this event. So let's keep it going and show our support at the event. So it's our biggest event of the year. Yes, it is. Very exciting.
And Katie, if you wouldn't mind, stay standing and come up near your birthday buddy, Sally. I want to just say a happy belated birthday to Sally.
Sally.
Who's not much older than Katie.
Nope, not at all.
And a happy almost birthday to Katie Morello, whose birthday is tomorrow. We've got some cake and some exciting stuff to happen after that. But happy birthday.
Happy birthday, Sally.
And that's all, folks. We're going to call it a wrap. Come get some cake. Thanks, everybody.
So I'll be brave if you're brave. I'll be brave, but only